Um, Thank you, Neil, for this very kind introduction. Thank you, everyone, for taking the time to spend some time. I'm honored to be able to give this lectureship. And let me just share my screen. And as Dr. Schechter mentioned, he and I worked for many, many years together. And I think nothing epitomizes more the nature of pain when you really look at the multidisciplinary approaches that different specialties can give. So the cross-fertilization between a gastroenterologist and a pain specialist really, gave us a lot of insight and a lot of possibility to really help these kids. So I'm really honored to have worked with Neil, and I'm really honored to be here. So these are my two disclosures. I am consultant for IHS, grant support from AVI. I'm gonna mention both. The IHS is what does the IB team, which I'm gonna mention, and AVI is linaclotide, which I'm also gonna mention. But I don't have any honorariums from them, it's just consultant. So the objectives of my lecture today are different, are three. I'm really gonna talk about the pathophysiology because the big complaint we get from our patients is that patients with severe abdominal pain get the message that all this anxiety and everything is in your head. And I'm going to try to show you what do we understand about the pathophysiology and what can we do. I'm really going to try to be a little bit pragmatic about the treatment goals and strategies and show you a little bit of the approach and what are the advances, where is the field, and what can we do for these, my patients with chronic abdominal pain. So what we called functional GI disorders are these conditions that are characterized by these chronic or recurrent GI symptoms that don't have a biomarker, right? You don't have a biochemical or structural abnormality. And that's what has been labeled as functional GI disorders. Now the name has been changed because the functional connotation has this prerogative issue that all this is psychological and it's not a real disease. So through Rome, we've been trying to really change the name to disorders of gut-brain interaction. I know in the pain literature, some people call them primary pain problems. I think we all understand in this audience what is what we're talking about. These kids with a real disease, severe pain that get just not treated appropriately, and many of them are labeled as everything is in their head. It's a very prevalent condition. There's no major studies in pediatrics. You can see here, this is the global Rome epidemiological study, which is mostly adults. And you can see the prevalence, it's everywhere. It's all over the world. If you look at the children information, there's been population studies that show that if you go to schools, abdominal pain complaints are really up to 20% of school-age kids. In younger kids, is less, like 3.8, but we even see it in younger ones. And 50% of the GI consultations are related to these functional GI disorders, not necessarily pain. Many of them can be related to constipation, reflux, other things. And if you go to a primary care pediatric visit, 2 to 4% of these patients have these conditions. So they are very prevalent. Now, why do we even care? We care not only because of the quality of life of the children, but these are associated with long-term problems, right? If you follow patients with chronic abdominal pain, you see that they have a higher incidence of depression, anxiety, psychiatric disorders, somatic complaints. They miss more school, and missing school, as all of us know, leads you to undesirable outcomes in adolescence. Really, has a major impact in their life. They have less academic performance. They drop out of school. They go into substance abuse, more violence. They clearly have more somatic pain also, and psychiatric symptoms when you follow them 5 years later. And most importantly, a third to half become adults with pain. So if we could understand what to do with these children, keep them in school, and avoid from them becoming lifelong adults with pain, we're going to make a major impact, on society. Now, I told you about the quality of life. This is a study we did a few years ago. And the only reason I brought it is you can see all the domains of, quality of life. I wanted to point out that the patients with functional disorders, so DGBIs, abdominal pain and IBS, have lower quality of life with patients with organic, quote unquote, inflammation of the intestine like Crohn's and UC. And this is something we see all the time. And I'm sure you see yourself in fibromyalgias, all these kids with POTS, all these kids with overlapping pain conditions, the same issue occurs. Now, how would we diagnose functional abdominal pain disorders? And my talk is not about how to diagnose it, but it's very easy, right? We're all looking for the porcupine. We all want to do a test, find the reason, give them therapy, and go away. Like, following sore throat. You get a sore throat, you do a culture, it's strep, you give penicillin, goes away. That's the dream of every physician that follows the medical model in the office. We want the patients in and out and find their diseases by doing one test, giving therapy, and it goes away. Unfortunately, in a lot of the pain problems we see, and I'm really focusing on GI pain, we have no biomarkers, no blood tests, and no structural abnormalities. So the diagnosis is symptom-based, which is always very tricky, because if you don't have the right approach, symptom-based becomes this area where there doesn't seem to be a diagnosis, there doesn't seem to be an understanding, and the patients really get labeled as everything is in their head. So this is the problem, right? In pain, and you are pain specialists, many of you, and you deal with this more than me in many ways, pain is a subjective experience. And we all know that. This is how a patient of mine painted what she was really feeling. We are nobody to judge what the pain perception of our patients is. That's how they perceive it, and that's what we need to address. So the pain is more a perception. It's not an individual, biomarker thing that you can find. Because abdominal pain was so complicated to catalog, and I'm old enough to tell you that in the old days, I was not Dr. Wayne Apley had his criteria, but eventually those evolved. The abdominal pain used to be called RAP, recurrent abdominal pain. And because these kids with chronic pain are so complex and so hated, in my practices, they used to call them crap. Knowing this, once the Rome group got together, the assessment came about that to be able to facilitate research and to be able to validate the illnesses that are real in these patients, we needed to follow what the DSM has done for the psychiatric illnesses, right? And one of the founders of Rome, Dr. Drossman, had that insight. So the GI functional field changed completely to try to emulate what the DSM does. And the model is the same. You're doing symptom-based diagnosis, and then you catalog them. And as you can see, now there's 4 predominant functional abdominal pain disorders that were diagnosed by ROM4. And you're going to say, why is that? And again, I told you, we don't call them that anymore. We call them DGBIs, which is a terrible name. It's hard to say, but that's the name we have so far. Why was it important to define it? First, because it validated the diagnosis. You can see here the amount of literature that evolved once we had good criteria and we started to do pathophysiological studies and controlled trials to treat the kids. The field just took over, and this was really life-changing. What is the ROM4? Just for you to understand, the ROM4, always has different characteristics. In this case, we're talking about pain, and one of the characteristical patients we see is what's called irritable bowel, right? So you have abdominal pain as the presenting sign, and we have other things. Are there any associated symptoms? When you have defecation-related symptoms, we call it IBS. The same pain, if you have nausea and pain at eating, we call it dyspepsia. The same pain, if it's paroxysmal, we call it migraine. The same pain, if it has nothing else but pain, we call it functional abdominal pain. My message throughout this talk is going to be that all of these patients have the same pathophysiology, and we're trying to put them in buckets that are artificial, but do help us treat the dominant symptom. But that's what the wrong criteria, right? So a criteria, the symptom, what's related to it, there's frequencies, and you're going to say this is magic. It was magic at the beginning by expert opinion. Now we have multiple factor analysis, epidemiological studies, and validation studies that really differentiate and show that all these criteria and duration are valid and really allow you to detect a population with a specific symptom-based diagnosis. What makes the diagnosis very, very hard is this statement, right? Which is in every one of your own criteria. It's after an appropriate evaluation, the symptoms cannot be fully explained by another medical condition. And this is very important. Rome 3 didn't have that. It says after organic diseases were excluded. That's a very different concept. What do I mean by that? And many of you are pain specialists. We all know you can have a quote unquote organic disease with functional pain, right? In my area is irritable bowel syndrome associated with Crohn's disease. But Dr. Semsky is here. We see a lot of sickle cell patients with functional pain. We see pancreatitis patients with functional pain. So these Rome criteria allow you now to say, if you've done an appropriate evaluation to be sure that the disease they have is quiescent and they continue with pain, you don't need, in the case of IBD, to give them more Remicade or do more endoscopies. No, you need to treat the pain as an illness. The only problem is we are specialists, right? But for a general practitioner, once you see this number 3, the question I always get is, how many tests do you have to do? I mean, how do you know you really have a diagnosis? How do you know that the patient in front of you doesn't have porphyria, which, in my life, I've seen 2 porphyrias, right? But people always focus on the zebras, and the younger you are, the more tests you do, right? So Rome is moving to trying to find biomarkers, and I suspect that not in my lifetime, but in your lifetimes, we're going to be able to have better understanding of the genes involved and the screening and the pathophysiology, and I think these diagnoses are going to become much more objective and less subjective, and the families are going to accept it more, right? So this is the question, right? If there's no organic pathology and normal testing, how can I be sure there's nothing else, right? And people live for this. And I can tell you, sometimes I go home and I don't sleep well after I've seen some patients because you are not sure. But you have to moderate yourself and really have a plan to try to be thoughtful about what you're going to put the kids for, because making a diagnosis can be a challenge, as sometimes it's unclear when is enough and what do I do. And I had the pleasure of writing a paper with Neil that I suggest for all of you about the over-medicalization that doctors cause by doing more and more testing and by trying to find things that are not there to be able to label the patients and avoid the idea that functional diseases are real and occur even though you don't have a biomarker, right? Doing testing is a nightmare for the kids, but it's a nightmare on society. You can see here the cost. We recently completed a study with more than 2 million people, and you could see that $6,000 more than controls is involved in patients with chronic abdominal pain. The older you are, the more pain you have, the more you spend, and this has been validated by other studies. So it's a very, not only invasive, we put the kids through a lot, you don't give them a diagnosis, and it's very, very costly, right? So the diagnosis has to be symptom-based, but there's a million diseases. All of you that are in the audience and are pediatricians or MDs, I could write 3 books on what gives you abdominal pain. So, and we cannot do everything to everybody, but I can tell you that sadly in my chronic abdominal pain clinic, which of course is a quaternary clinic for the most intractable kids, 30% of my patients have had not only 20 endoscopies and colonoscopies and CAT scans, but 30% have had laparotomies, looking for the reason of the pain, right? And this is something we're all trying to change, and in the spirit of the pain treatment, to try to avoid and allow the diagnosis to be easier without being so invasive, which is, has a big toll. So there's some alarm symptoms that need further investigations, and you have them here. I don't have time to go through all of them, but if you look at the Rome criteria or you see here, there's some things that should make you wonder, okay, am I really dealing with a functional kid, or do I need to do more testing? Clearly, family history has become super important, but you can see the weight loss, the vomiting, and I don't have time to go through all of these. But in general, history and exam can and should direct your workup. And all of you in the audience that have seen these kids have a gestalt of the patient. You see the patient and right away you say, oh, I suspect this patient has functional abdominal pain, right? I hope you could change your framework to say, okay, I know, and then maybe I can really move into explaining to the family that that's what it is, without going into the conundrum of I'm trying to find the reason for your pain and I'm going to do all these tests. And if the tests are negative, therefore you have a functional disease, right? We've spent our lifetime changing that approach to try to make the diagnosis of these functional disorders into a positive diagnosis. You see the patients, you think that's what it is, and you give a diagnosis immediately. I think you have functional abdominal pain. I don't need any tests to know that's what you have. It's not a diagnosis of exclusion. I'm not sitting here saying you don't need some screening labs, but the message is different. If you say, I know what you have, I think you have functional pain, I need to do some tests looking for triggers of the pain, right? It's a very subtle word, triggers versus reason. But if you explain to the families and the patients, I'm looking for a trigger of the pain, and your test is negative, okay, I didn't find a trigger, your pain is the problem. But if you say, I'm looking for the reason, it implies you don't understand why the pain is there. You have a negative test and it's negative. Okay, what do I do next? You did a test to look and you didn't find the reason. What's the next test? Is it going to be a CAT scan, an MRI? So if we could convince pediatricians and general GI, and I'm sure in the pain, sir, you know, you have musculoskeletal, many other pains. If you could convince them to give a positive diagnosis and not a diagnosis of exclusion, we're going to avoid a lot of testing, right? So what's the information we have about this, right? So again, don't say you are excluding the disease. It's very costly. Always, you have to do testing for alarm signs, and I always frame it, I'm not looking for the reason, I'm looking for the triggers, right? You are going to tell me, Dr. Nurko, you're a GI, you should do an endoscopy in everybody because the families want an endoscopy. If you do an endoscopy and endoscopy is negative, you are going to reassure them. There's at least 2 studies that have done, one in pediatrics, one in adults, that have shown that if you do an endoscopy and the endoscopy is negative, you are not only not reassuring the patients, you are creating more issues. Why? Because more testing implies that you don't know what's going on and gives the wrong message that the reason of the pain is not being discovered. If you do it for triggers, it's a much easier work back. Can I have a patient that I say, I'm looking for the trigger and I find IBD? Of course, those are the easy ones. Look, I found it. You have inflammation, you have Crohn's disease. That's very easy to go back. But the other way is a much harder sell. Again, don't do it for the finding the reason, you know, because it's never ending story. So what the crux of the matter is, and I use the example of the strep throat, right? The medical model where a lot of us grew up in medical school talks about these quote unquote organic disorders, right? There's going to be a pathological, a biomarker. You find a test, you do something, you do medications, and they get better. All of us know that chronic pain does not follow this paradigm, right? We have to talk about the biopsychosocial model, and all these functional GI disorders are more related to the experience and the illness experience, and it's more symptoms. It's a symptom-based diagnosis. So the treatment is more geared toward taking care of the symptoms. And as I'm going to show you later some data, many times by treating the disease, and I believe that the pain is the disease, by treating the pain, families think we're only treating the symptoms, not the disease. So you have to bring them back to explain. It looks like I'm treating the symptoms, but that's what your disease is. You have pain as the disease, and we have to treat every symptom associated with it because those are the triggers that can make it worse, right? So we need to treat the motility, proneness, the sensation. So the treatments are very, very different, right? And I don't have to tell a pain audience what the biopsychosocial model is because you're an expert at this, but this is results of the intersection between your biological predisposition, right? And we know there's a genetic predisposition, you know, and there's social factors, environmental factors, and psychological factors that are the ones that lead to the development of these pain conditions. In my case, I'm really focusing on functional GI disorders. You know, one great example of the biological intersection with environmental and social is there's a great study from Rona Levy where she followed prospectively twins, and some twins were monozygotic and some twins were dizygotic. As expected, when she looked at the data, monozygotic twins had much more pain as compared to dizygotic twins. However, what I didn't tell you is she followed pairs of twins that were adopted into different families. So once she controlled for the families, there was no difference between monozygotic and dizygotic twins, and there was a clear influence of the environmental and social factors that really created the pain, right? Nature versus nurture. And both things are very, very important. Why are the biological things important? because you have Ehlers-Danlos, all these things that predispose you to pain, right? So coming back to this, I told you, I use metaphors, and this is something that Dr. Schefter and I did all the time, and Dr. Coakley. Clearly, we try to understand pain, not a symptom of a disease, but pain is the disease. And we use a lot of metaphors, right? The pain is really hurtful, real, but is not harmful. You don't have cancer, you don't have an appendix that's going to rupture. We use the hardware versus software analogy, right? If you do testing, the hardware is normal. It's more a software problem, like when your computer stops working and you need to do Control-Alt-Delete. You know, when you restart your computer, it works. If it was a hardware problem, it wouldn't work. So that's the point of not doing testing, because we're not going to find the testing and we cannot see the software, right? It's like a false alarm. You have a car and the alarm is there. The alarm is real, but there's nothing producing the alarm, right? And these are type of metaphors we use. We use a sunburn. It's like your nerves are increased, and when you're sunburned and you touch, it hurts. Once your sunburn goes away and you touch, the same touch doesn't hurt. So the problem is not the touch. The problem is the state of the nerves that are receiving the touch. And I use that all the time to explain why food can be painful. It's not the food, it's the intestine. Or stool can be in the colon. It's not the stool, it's the colon, right? And that's very important. So you need to bring back and understand this. So what do we know besides, this is nice theory, right? But is the pain real? Is it loading your head? Do we have any scientific evidence that what I'm telling you is correct or not? Unfortunately, now we have a lot of things. I can just unequivocally say, I could stop my lecture here and say, yes, if you get away from this, lecture, that you have to say the pain is a positive diagnosis. I don't need testing. I'm looking for the triggers. And the next thing is the pain you have is real. Then I've accomplished my objective today, right? But I want to be scientific. So what do we know about this pain? And the interaction between the mucosa, the microenvironment, and everything else that goes into the central nervous system, including the spine, the ganglia, is very complicated. But now we know a lot of the pathophysiological mechanisms of visceral pain. In this case, functional abdominal pain is a visceral pain. But this model applies for many other pain conditions, right? So there's visceral afferent hypersensitivity that could start with inflammation, and there's other things, right? What does this mean? As I said, things that should not be painful become painful. So if you have food in your stomach, it's not normal to have pain. If you have poop in your intestine, it's not normal to have pain. Is there any evidence that these patients really have hypersensitivity? And the answer is yes. We have rectal varostat, which are compliance balloons you can put in the rectum or in the stomach, and the study clearly demonstrated. You can see here the pressure and when do you start to see the pain. You can see that patients with IBS reach pain at much more volumes than patients with even abdominal pain and healthy controls. And when you put the balloon in the stomach, you could see that patients with abdominal pain, that's upper pain, had much more pain as compared to the other ones. So yes, we have evidence that you have hypersensitivity of the viscera. This is a peripheral thing. But this does not live in isolation, right? The intestine is not outside. And we know that it goes through not only through the autonomic nervous system, but also through the spine. And there's a lot of animal evidence that showed that you have firing from the spinal cord and different centers that are going to increase the amount of stimuli that go into the brain. The same is from vagal efferents and other sympathetic, conditions. So it's very hard to do in humans. In animals is well shown. There's 2 studies in humans, in patients that were having spine surgery and they did different stimulation, that you can indeed see that the firing of the spinal neurons is increased in patients with chronic pain. Now, what about central sensitization, right? The pain is in the periphery, but it's perceived in the brain. What do we know about the brain? And as you know, with the advent of functional MRI, and now we know the circuits of the pain, there's many studies that have indeed, in my field, shown that the circuits that deal with the pain are abnormal in patients with chronic pain. We've done 2 of them. You can see here, actually, Neil was one of our collaborators. What you can show is that the areas of the brain that feel pain, which are very well described, are magnified in patients with chronic pain. So not only do you get more pain with less, meaning if you put a balloon in the rectum and you give 20 cc's in a patient with pain, you're going to get maximum pain. If you do it in Nurco, you need 200. But once the 20 mLs give you pain in a patient with chronic pain and hypersensitivity, the brain of that patient is going to light up. The areas of the brain that feel pain are much wider and bigger, and there's a clear relationship between the duration of the pain and the amount of lighting up of the brain. So if you do it in me and a control, the pain center goes up, but it's very small. Then what we also show is that the circuits that make you aware of the pain are increased. I always use, and we have people from all over the world here, I always use the analogy that I have a little street going from the areas of the brain to the consciousness, but patients with chronic pain have like a mega highway. So they get not only less pain, more pain with less, more activity in the brain with pain, they get much more activity to be cognizant of the pain, and then all the inhibitory circuits that we can also measure in functional MRI are decreased. So they cannot get rid of the pain. And that's a circuit. That's, we try to use the fMRI as a biomarker to be able to show the families. It's very expensive. It's very hard. The circuits are there, but it's very hard to interpret. But, my dream was to be able to do it. But yes, we found a biomarker of pain, but it's very hard to experiment with it to show it for the patients, right? So yes, hypersensitivity, abnormal neuronal responses. Yes, you get central sensitization. But what about the observation that all of us have, that if you have anxiety, depression, and catastrophizing, your pain tends to be worse? Is there any experimental correlate to this? And yes, for doing functional MRI, this is a classical experiment that I love. You can see here you have healthy controls and patients with pain. You can see here the patients got, again, rectal distension. You can see how the areas of the brain increase. So you can really see the biomarker of pain that I was telling you about compared to the controls, right? The beauty of this experiment, they came and said, okay, I gave you 20 mLs in your varostat. I'm going to give you 200. When the patients here, they're going to be exposed to something that's going to be very painful, the expectation of the high intensity distension triggered the circuits of the brain, like if the balloon was bursting, even though they did not inflate the balloon, right? And this is what proves the association between your expectation and catastrophizing in the pain. And even though I am the first one to tell you the pain is not in your head, once you really go through the pathophysiology, you can explain to the families, it's not psychological, but clearly your psychological makeup doesn't help it because can trigger these circuits of the pain. And this is what explains how do we treat the pain, right? Because you need to do the periphery, you need to take away the triggers, you need to change the central sensitization, and then you need to change this expectation and catastrophize, right? The final frontier, obviously, I could not leave this talk without talking about the microbiome. Now we know that what you have in your intestine changes everything. The microbiome has been shown to be different in patients with IBS. If you take stool IBS patients and give it to rats, they get IBS. Now there's 3 studies that they've done fecal transplants for patients with IBS. In 2 studies, the pain went away. In 1 study, it did not. But there's animal models that your microbiome changes your brain chemistry, right? There's a lot of things we don't know, but it would be very simplistic not to include the microbiome. And you'll see the difficulty with the microbiome field, as you know, there's many variables, and there's still no microbiome marker that really tells you this patient has IBS or has this. And now we talk more about the metabolomics effect, right? What are the mediators? And I think that's what the field is going to show us in the future. So how do we conceptualize the pathophysiology of pain? You have genetic predisposition, with a family history, and that has both ways, right? It could be the environment and your genetic predisposition. And again, this is where I put your genetic Ehlers-Danlos and all those things. You have, now we know, and this is a thing that I'm sure you know, you have early life events that predispose you for pain. If you are a baby, a premature baby, if you have pyloric stenosis, if you had allergy, if you had a UTI, if you had your appendix out, something in the right environment is predisposing you, to have pain if the right stimuli occurs. And that could include also psychological trauma, right? So I see it as a volcano. You start to build up the volcano. And then something happens in this volcano and you get a trigger that just triggers the pain and the volcano explodes. All this insight in my field came when in Canada there was a mega infection with like 20,000 people that developed an infectious condition. And after the infection was gone, 20% of the patients continued to behave like if the infection was there. This is what we call post-infectious IBS, which is 30% of our patients. And when they saw this, that's when the study started to say, why are these patients having symptoms even though the infection is gone? And what makes them different from all the other 18,000 or whatever that got better, right? And that's how this field started to change more. So now we know that these triggers are paramount. In our own practice, the infection can be GI. We see 20% of non-GI infections, UTIs, otitis media, surgeries, a broken bone, another type of surgery, or you can have traumatic events, the parents divorced, wars, many different things. And we found concussions. We have many kids that develop concussions and then develop abdominal pain. This is in the setting of the right genetic predisposition. Now, what makes the disease then continue? You have resilience factors and you have the vulnerability. So it's a very complicated model, but this is how we conceptualize it, right? So we understand all this, the pain is real, we know the circuits, there's real abnormalities. What's the treatment of the pain, right? I find, and Dr. Schechter and I also wrote a paper about the 5 minutes that you need to spend with your patients. There's no time in clinic to do this, right? So we could get the right messaging, that's very important. So what do we know about this? The explanations are very important. First, the pain is real. You have a diagnosis that's positive. I don't need any test, and this is not imaginary. I want to do tests again to look for triggers, not for the reason. Is the hardware versus software harmful versus hurtful thing? You have to say this is not a medical model. This is a biopsychosocial model. It's a life experience. And no, it's not in your child's head, right? We always say you are complicated. You've been through a lot, but you're not a mystery to me. I know exactly what you have, which tells you I know exactly what to do. We've done questionnaires, and this part of giving a positive diagnosis, reassurance, and telling them the patients they are not zebras, and we've seen it all the time, is one of the first steps in the rehab process and in the rehabilitations for this, because when you have the fear of the unknown, it overrides everything else, right? And then we do analogies with more other conditions that have other functional things, right? When you have a migraine patients, they accept it. Nobody in migraine, they are asking you to do a brain biopsy. The abdomen, unfortunately, has so many organs and the surgeries. And so it's very hard to convince somebody that you don't need a laparotomy with this. But, we use the analogy of the headaches, right? And that's why we say it's chronic and recurrent, and there's triggers. And then we compare that the treatment is not a medical model. I'll give you one medicine. No, it's a rehab model in which, like a rehab from a fracture, you are going to have to work hard. There's going to be pain, but that doesn't mean you don't function, because the most important thing is functioning. So how do we conceptualize this before we go into the specifics? So you establish the diagnosis. Yes, no matter what I think, you need to see the dominant symptom. If the patient is coming for IBS, and I think his problem is central sensitization, but he continues to have constipation, I need to treat the constipation, because that's what the family is focusing on, right? So always remember, you need to identify what's the dominant symptom. We always have an open-ended question. What's the worst thing? And sometimes you are surprised. I mean, what they tell you. So you have to address what the family's expectations are, right? You need to see what other factors. We see a lot of patients with overlapping pain conditions that I'm sure is the vein of your existence, like the vein of my existence. Then you have to perform diagnostic tests only as screening and to look for triggers, right? We are in an epidemic of MALS, muscle activation, all these other things, because there's a lot of tests and then you don't even know what to do with the information, right? And then you need to initiate treatment based on what you think. And then this is the crucial part. It's not that I've never missed a diagnosis. It's the fact that the trick of doing a functional diagnosis is that you're going to follow the patient. If you see the patient and say, bye-bye, I'll never see you again, that's when mistakes happen, right? I always tell the families, I have the right of changing my mind as things are progressing, right? So if you see the patients often, then that's how you avoid. That's how you avoid mistakes. I'm not telling you lies. It's not that I see the patients. I've been able to build a team, and I have an MP that can do all these follow-ups and all these things, and she's been a godsend for me, right? Because TLC and caring, that's what the most important thing that these families want, right? So if you really go into the nitty-gritty of the treatment, what are we trying to do? We're trying to target the components. If you followed my pathophysiology and you agree with me, then we have peripheral problems and central problems. And how you treat peripheral issues is very different than central periods. And sometimes you need to do a combination of both. So what are the peripheral things you can treat? You can treat the motor effects if they have diarrhea, constipation, cramping, the sensory effects, all these hyperalgesia that you have, 20 hours in the bathroom, food hurts, the triggers, diet, and I'm going to talk about the diet, right? If gluten is giving you problems or FODMAPs or whatever, those are things. And there's other things that, you know, more and more focus. What does duodenal eosinophilia mean? What is the microbiome? I don't want to mix you up with this, but the field is going more to try to understand the pathophysiology at that type of level to see if there's specific treatments, right? And if we all think they are disabled, they probably have central sensitization, then you need to deal with that and the anxiety associated with this. So always employ the treatments based on the most likely target. Biomarkers, I told you, there's many ones. I can tell you the story now. IBSD can have bile salt diarrhea that we've discovered markers for. So I suspect that in the future, we're going to be able to know more and more on personalized treatments. I can give a commercial to say, for example, there's a recent study where they did exomic sequencing and they found that the genes that are related to anxiety and IBS are very similar and shared in a lot of these patients. So I suspect in the future, we're going to be able to define these patients better, right? So if you look at the treatment, then what do we have? The first thing we have is a pyramid, and you have to escalate your therapy according to the severity of the patient. You know, a patient that gets in primary care is very different than a patient that comes to my clinic that they've been out of school for a year. So you need to try to decide, is this a peripheral problem, a central problem, both, and how disabled is the patient and how aggressive do I have to be, right? We use the model that, you know, has been proposed by Rachel Coakley in our place, and we use that same thing. I'm sure you've heard it. We see this as a tricycle, right? You can name the wheels any way you want. I don't want to be a prerogative person to say that the first wheel is the medication, but you know, one of the wheels is medication, finding the triggers or the medical things that me as a gastroenterologist or you as a pain specialist are going to do to look for the triggers, and then medications to tone down the nerves. Then the second wheel is the psychological interventions. What can you do to change the brain circuitry, the catastrophizing, and the approach? And the third wheel, which is the most important one, is function. We need to provide the ability and for the patients to function. That's what you want. And if you go from the bottom up, we're going to do from dietary and relationship, then we try to do all these are peripheral things, and then finally you get into the more sophisticated things. All the time thinking, do I need more psychological support? And what do I do with all these overlapping pain conditions, right? So what do we know? The medical relationship between the doctor and the patient is important. This is a classic study of Dr. Kapchuk, where you could see, and I don't have a lot of time to go through the study, but augmented interventions versus sham acupuncture and waiting list. When the doctor spent time with the patients, it's not a surprise that the patients were better. In this controlled study, they showed that warmth, empathy, duration of the interaction, and the communication of a positive expectation is exactly what leads to a better outcome. So we are very positive when we see our patients realistic, but positive. We just published, you know, Neil was part of this, an open placebo study where we actually took patients with chronic pain that come to my clinic. So they are semi-intractable. And we took them and say, I'm going to give you nothing and just follow you, or we're going to give you an open placebo. We told them it was open placebo. We told them it was something inert. And you can see the patients on open placebo did better than the patients in the no treatment control, to the point that the patients, you know, we gave placebo twice a day. The patients would call me, Dr. Nuco, can I do it 3 times a day? Because it really works. At the end of the trial, we had to get an extension of the IRB to be able to continue to give placebo for a whole year, because many patients, we stopped the placebo and the pain came back. This just shows you how complicated things are, but how these interactions and explanations, there's a lot that we don't know. But there's no question that the placebo effect and how to harness placebo is going to be part of the future, right? What about triggers? We have a lot of dietary factors. Fiber has been shown to be very effective for patients with IBS, particularly constipation type, decreases the pain. Lactose-free diet has also been shown in some patients to really decrease the symptoms. So we tend to give a 2-week of lactose-free diet. But then the kids in the block that everybody's using now, all my patients are on gluten-free diets and the low FODMAP diets. And there's also some evidence of probiotics. Again, I don't have time to go through this. This is a Rome position paper where we reviewed all the literature with all the dietary things you can use in patients with functional GI disorders. In red, you have what's proven by evidence. In green, you have what's still controversial. And when you come to IBS and DGBIs, clearly soluble fiber has been shown to be effective. The low FODMAP diets and all the rest, there's a lot of evidence, but there's some equivocal thing to the point that if you actually look at the literature, the low FODMAP diets are very complicated to do. You know, even though there's 2 controlled trials that work and 1 that does not work, all the organizations say there's still insufficient evidence. Not everybody should go on a low FODMAP diet. If you have more bloating and diarrhea, you respond better. And what I want to say is be careful. We're seeing an increase in eating disorders associated with DGBIs. So before you start to give restrictive diet to your patients that already have nausea and pain, you have to be very careful, right? Because eating behaviors can be triggered by the doctor's interventions when you're trying to do these elimination diets. And our field is really trying to sort out who are these RFID type patients with pain. I think they are a different population than the typical RFID, you know, that had a bad experience. This avoidance with anxiety is a different population. So you need to be very careful with those patients, right? What about I told you, the probiotics? There's 2 studies that show probiotics really in controlled trials help. You keep moving into the periphery, you start to mess around with how the nerves work and everything else. And these are the different interventions, right? From antiacids, antihistamines, antispasmodics, and I'm going to show you some data. Ciproheptidine is our main drug. It's been shown, it's an antihistamine, but it's main shown to reduce the pain frequency. It's very well to prevent headaches and even abdominal pain. Again, don't ever give ciproheptidine to a patient that has food aversion and a lot of pain when they eat, because imagine the result when you're anxious or eating and you give a medicine that's going to increase the appetite, you're going to precipitate a crisis, right? But if there's no issues, we tend to use ciproheptidine as a neuromodulator. There's controlled trials that taking away the acid may help. And then you start to see, and I love this study in adults, because everybody poo-poos Tylenol. No, there's a study in adults that clearly showed that if you give acetaminophen, the effect is better than placebo. And the other thing they compared it with was anticholinergics, right? If you look at how the intestine works, and you are going to see that I'm going to show you a few times, the anticholinergics really have, you know, affect the muscarinic receptors and other areas that give you contractions. And there's a lot of evidence in pediatrics that the use of antispasmodic is effective. So yes, you can use an antispasmodic. I use a lot of Nulev and Bentyl, and there's studies that show that has been working. What about peppermint oil? That's the new kid in the block. There's something called IBGuard, and there's studies also that show that if you use peppermint oil, again, changes your periphery, changes your constipation, and takes away your nerves. So yes, we have evidence that peripheral treatments work. What about all these new kids in the block that we use that have bases, right? If you look at the pathophysiology of things, you have new treatments for constipation that are much more geared towards physiologic changes in your smooth muscle and how your intestine works. Miralax draws water, right? X-Lax just contracts. These are like guns. They are not specific. Now we know there's a series of medications that have a specific effect on how the sodium and the chloride are absorbed. And this is the ones we have in the market. I don't have time to tell you about the differences, except to tell you that linaclotide was just approved by the FDA for the use of constipation in children. Why do I have linaclotide in a talk like this? Because as I'm going to show you, linaclotide has a major effect on sensation. So these secretagogues have not only a motor effect, but they also have a sensory effect. The other thing you can do now, besides changing the absorption, you can change the peristalsis. We have motegrity and prucalopride. It has not been approved in kids, but it's also been shown not only to improve your constipation, but improves gastric emptying and changes the pain. So these new medicines can give you a much more tailored approach to your patients with a chronic GI functional condition, depending on the predominant symptom, right? And then we all use, and we're going to talk about amitriptyline and all that. I just wanted to bring this up to show you that the antidepressants have a peripheral effect too. They also change the chemistry and the perception of the hypersensitivity. So you're not only changing the brain, you are also facilitating changes in the periphery, right? And finally, in kids with severe distension, there's evidence that SIBO is a disease. I don't do tests for SIBO. I don't find them good. I don't have time to explain why. But usually we use non-absorbable antibiotics for these kids with IBSD. And the reason I wanted to show you this is what people focus on. Again, as you can see, the effects are small, but it was approved by the FDA. The point I'm making, once you give a course of rifaximin, you should expect you need a second course. The Target 3 study showed you give it, it works, and then people are going to rebound. So if you are going to use rifaximin, expect you're going to have a rebound and you're going to have to give 2 courses. And that's why I wanted to bring this, right? But as I told you before, you are dealing with all these, you are dealing with all the peripheral effects. Psychological interventions go hand in hand and should be used early because not only to treat the anxiety, but to change the pain behaviors and the catastrophizing, right? And there's 2 conditions that have been shown to be more effective than any medication, CBT and hypnosis. These are the studies that really show that the standard therapy from Norco is not as good as the hypnotherapy. This study was short-term. Now you can see 5 years later, the benefits of hypnotherapy are still there. And the beauty of this approach now is we have apps that allow you to do either by CD or by apps, hypnosis at home. And they've been shown to be as effective to the point that, as you know, now there's FDA-approved CBT and hypnotherapy apps that people can use to do this. So these should be used sooner than later, and they are a very good adjunct for our patients with chronic pain. Now, what happens when the anxiety is really overwhelming and it's just not letting you improve, and you try CBT and it doesn't work and you have other products? That's when we start to see in the more severe patients, can we change the central sensitization with the use of neuromodulation, right? And the neuromodulation has many different aspects. I told you, I put here ciproheptidine because that's the first one I use. But then you have 2 big families that you are more familiar than me in this. The antidepressants and the anticonvulsants. And the antidepressants, as you know, you have these 4 groups that I'm going to touch about. They're very different in the way they deal with norepinephrine and with serotonin. And then you have the anticonvulsants, the gabapentin and the pregabalin, right? So talking about the antidepressants, now there's a lot of evidence. You use those medicines depending on what you're treating. For depressive symptoms, you can see here SSRIs, SNRIs, TCAs. For anxiety, the SSRIs. I mean, you can need it. When you have eating disorders, this is what you have. And for pain syndromes in general, the TCAs and the SNRIs are the ones that are used the most and have been shown to be positive. In adults, SSRIs have never been shown to be good for primary pain, but in pediatrics, there's one controlled study that shows that indeed maybe. So in my clinic, we use SSRIs when there's a fair amount of anxiety. This is the experience in pediatrics. Just a summary to tell you that in general, open study, this is a review, all the faults, but you can see once you use it in the right patient, a lot of patients really improve with the use of these SSRIs and TCAs. And I just want to show that in my field, more and more we're using TCA, we're using the tetracyclics, we're using a lot of mirtazapine, which is Remeron, because that really changes your nausea, your vomiting, your anxiety, and your appetite. So in kids with upper symptoms, this has become our go-to drug, and it's been particularly effective in these patients. Now, what about gabapentin and pregabalin? As Dr. Schechter will tell you, we use it a lot. I know the systematic reviews don't show a difference. There's one study actually that showed that there was no difference compared to placebo, but the fMRI was significantly different, and the patient's global impression of change was higher in the person. So we tend to add this an adjunct when nothing else is working. But all the systematic reviews, to be fair, have shown gabapentin doesn't work, antidepressants don't work, But the recommendations of every specialist is that, yes, in cases that are severe, you can try and discuss we like to call neuromodulation, not antidepressants, right? And depending on the main symptom, IBS, IBSD, IBSC, then you can see what we use first for the periphery, the linaclotide or other medications. Then you start to augment with the central effects, depending on what you mean, TCAs and SNRIs for pain, but we add the tetracyclics and SSRIs for anxiety and nausea. And then when that does not work, we try to augment it with other medications, right? The atypical antipsychotics, all these other medications that you use. In the adults, they put psychological treatments there. We use psychological treatments way before. And this is what I just want to mention too. Depending on the main symptom, you can decide how aggressive your psychological intervention is going to be. And I don't have time to go through all of them, but if it's pain predominant or anxiety or depression or mostly GI specific anxiety, the treatments are not exactly the same. So what are the new treatments? The first one is, if you believe the pathophysiology, now we know that if you can control the software and change the way your brain is working, you can change things. There's a device called the peripheral nerve stimulator that you put, this is the device, you put little needles in the ear, which has direct relationship to the vagus nerve, and animal models have shown that it works. When you do it in patients with pain, now there's 6 controlled trials, and we just finished a multi-center trial. This IBS team, which is the device that I'm showing here, has been shown to be effective, has no major side effects, and I can tell you this is the only FDA-approved treatment for chronic IBS in patients. So we got Blue Cross and Blue Shield of Massachusetts to approve it. So in Massachusetts, it's approved. So we're using this, and it's a very successful thing. What else has been invoked? We've done multidisciplinary treatment for a long time. Dr. Semsky has, I don't know in the audience, but integrated care is becoming a mainstay, including nutrition, medical management, and behavioral management, and that's what we have. This is my team. You can see we miss Dr. Schechter, who still comes once in a while, but you can see all the team. It takes a village to be able to do this, from social worker, nutrition, another GI, the nurse practitioner, and the 2 psychologists. I mean, this is our team, and we've shown by doing multidisciplinary therapy, look at the patients we got. I told you 30% with laparotomies, 10% missed a whole year of school, 87 missed school, they were not functioning. And after we did this hour multidisciplinary therapy, you can see we got improvement in most of them. And more importantly, we got at least 60% to go back to school and to be able to function. And the adults recently finished a placebo-controlled, a controlled trial of standard versus multidisciplinary randomized trial. And they show that even in adults, multidisciplinary care tends to be more effective than standard care. And this is something we need to use, because it's hard to convince our administrators that what we're doing is cost effective, right? They think it's a waste of time. You see 5 patients, you have 20 specialists there. I mean, what's happening there, right? But there's evidence that you improve the quality of life, the functioning of the patients in general, right? So I just want to finish by saying, there has to be a positive diagnosis. You have to tell them you're not a mystery to me. I'm doing tests to find the triggers, not the reason for the pain. You have to provide explanations. And even though I'm telling you it's not in your head, you could see all my patients go to the psychologist at the end, after you explain to them that the anxiety and what the role of anxiety is within the pathophysiology of the real pain disease, right? You need to set expectations, and the multidisciplinary approach is needed for the most severe ones. And as I showed you, there's a few new treatments that I think are going to revolutionize the care of these patients. Thank you.
Wow, Sam, that was outstanding. I think we could have listened to you for another hour, and you probably could have talked to us for another hour. But I'm going to just ask people if they have questions to put them in the chat. So feel free, and we will give a few minutes for Sam to answer if you're willing to stay on. So Sam, I'm curious, while we're waiting for other questions, are there larger trials that, some of these studies probably don't find outcomes because of their small sample size, some of the gabapentin things and things like that. Are there larger trials going on? Are there opportunities for folks to get involved in these trials, et cetera?
Yeah, it's a very important question. I would say there's two issues, right? The small sample size with the implication that the treatment differences are small, and in pediatrics, the placebo portion is what kills all the clinical trials, right? Because the placebo in this condition is 30 to 40%, right? So, for example, there's been a study with linaclotide. That's the first one that's controlled trial. They needed 800 children to find at 30% things, right? In prucalopride, in amitiza, we found the same as the adults, but because the placebo effect was so high, they are not significant, right? And that's what happened with the amitriptyline trial. But coming back to your question, no, unfortunately, no, because nobody wants to fund these studies, right? And pharma is not interested in funding this because you need a lot of patients. Now, there's a very large trial on tenapanor, which is a sodium, changes the absorption of sodium for constipation and IBS. Actually, I think you're going to be hearing more. I think that's going to be a new drug for IBS. They have a large multi-center trial. And yes, if somebody is interested, I can send you to the company. But otherwise, the big trials, I mean, the IB Steam was a big trial, but there's no other big trials.
Great, thanks. Dr. Walco from Seattle asked, can you say more about mechanisms leading to visceral afferents becoming so hyperactive?
More about we don't know why, but in animal models, it's been shown that once you start to fire, the neurons start to have action potentials all the time, and they continue to fire, and that changes your spine. And then everything converges to the spine, right? Even the autonomic nervous system has convergence into the spine. And that's why, you can have abdominal pain that you can really pinpoint to the other areas. I'm not sure if I'm answering the question, but this significant effect that starts to pile up that produces this excitability of the neurons that continue to fire. I did not mention, but all the allostatic load, which is how the brain gets loaded, is also very important into this, very relevant for all these overlapping pain we see.
Looks like Dr. Schechter might be asking a question. He put Dr. Nurko, but he didn't finish his question.
Oh.
Dr. Schechter, do you want to ask your question? He's having trouble getting off mute.
Yeah, here we are. I'll do it the old-fashioned way instead of typing it. Dr. Nurko, there's been a movement or a lot of discussion about acnes for abdominal pain, and I know we have our own opinions about it in the clinic and about the subsequent surgeries. And I wonder if you could talk about that's abdominal cutaneous nerve entrapment. Yeah,
it's a great question. And again, I'm going to come back to what I just said. There's something called the allostatic load, which is how much pain can the brain get to be able to compensate for life, right? So if you have POTS and joint pains and CRPS and all these conditions, the overload of your pain is such that you cannot really control it. What Dr. Schechter is mentioning is when you see patients coming to a GI clinic for visceral pain, the acne is usually missed and the somatic portion of the pain is missed. So we've found in our patients, probably 20 to 25% of patients referred to our clinic had evidence that their visceral pain was most likely more somatosensory pain. And we actually do tap blocks. It's very common for us to work with the pain service, Dr. Riley, Dr. Dinakar, and we do tap blocks. And we've shown that in many cases, taking away that extra stimulus of pain allows you to rehab the patients better, right? There's some patients that only have acne. I suspect those don't come to my clinic because it's very classic. But the ones that have acne together with all these functional GI disorders, if you find it, we tend to take it away, and that allows us to rehab better. So always look for the acne. There's the Carnet sign. There's different ways to do it. But yes, we've seen patients with pain for years and years, and what they really had was acne, right?
Any other questions? All righty. Well, thank you everyone for attending. Really appreciate it. If you want more information about ChildKind, or you want to listen to Dr. Nurko's excellent talk again, please check out our website, childkindinternational.org, and have a wonderful weekend.
All right. Thank you for having me.
Thank you, Sam.
Thank you so much, Dr. Nurko.
Okay. Bye.
That was excellent. Thank you so much.
Thank you.
Yeah. I think very helpful to everyone in attendance.
All right, bye.